Welcome everybody to the Sibley Memorial Hospital Gildenhorn Institute of Bone and Joint Health. My name is Dr. Scott Faucett, and my goal for you today is to talk about meniscus injuries and their treatment. And we'll have an opportunity to go over all types of knowledge about the meniscus, what they do, what happens when they get injured, how best to treat them. And then we'll also have an opportunity to answer any questions you may have about the meniscus. I'd like to start off by thanking Sibley Memorial Hospital for having us this evening, thanking specifically the Gildenhorns for their generous support of the Institute of Bone and Joint Health, as well as all of you for taking time out of your evening to join us. So when we talk about the meniscus, there's been a lot of news regarding meniscus tears in the lay press. Looking at the New York Times, a recent study saying common knee surgery does very little for some. Studies suggest others, another one saying useless surgery is still popular. And while I will posit that there still is an awful lot of meniscectomy and meniscus surgery being done that may or may not be helpful, there still is a role for addressing meniscus tears. And it's just important that we apply this surgery properly to our patients and not just for any tear we see. So my goal for this evening is to talk a little bit about meniscus anatomy and the function of the meniscus, talk about how meniscus tears occur, what the symptoms of those tears may be, what treatment options are available, and then if there's any arthritis in a meniscus tear, what should you do? And I'd like to take a little bit of a moment to stop here and just let anybody know that I would really enjoy to answer any questions you have. Please feel free to post those in the question and answer section. And we will address those at the end of the talk. So what is the meniscus? Meniscus is a fibroelastic structure. So it's kind of like a soft, rubbery structure that sits between the femur bone and the knee bone and the tibia bone in the knee joint. And it plays a role in changing the flat surface of the tibia bone, as you see here, to the curved surface of the femur. So it provides this conformity to the knee joint. Whereas if you had a curved formation of the femur on this flat surface, there would be a lot of force being produced right here on the tibia, and it allows for that motion to be somewhat dynamic as the knee bends and straightens. But you can see, its attachment on both the front and the back of the tibia bone, and this is the medial or inner meniscus, and this is the lateral or outer meniscus. And it has this curve-like structure. And then this is the gliding cartilage or articular cartilage. So many people may say, oh, the meniscus, I tore some cartilage in the knee. It really is important to clarify the role of the meniscus as being a structure that's separate than the gliding cartilage of the knee. And as you can see here, the meniscus moves. So this is the outer meniscus or the lateral meniscus here. And it has quite a bit of mobility as the knee moves back and forth, whereas the medial or inner meniscus does not move as much. And the role of the meniscus, again, is to provide that conformity of the concave on the flat or the convex on the flat or convex surfaces of the tibia and the femur. And it distributes this load across the knee joint, because if we didn't have the meniscus, this load would be forced in a very small area across the cartilage, and it will wear out faster. The meniscus is made up of a lot of fibers that run in what we call a hoop or circumferential-like fashion. These are circumferential fibers. Then there are other fibers that are running across these. These are called like tie fibers. And then there are the radial fibers that kind of wrap around these tie fibers, and these circumferential fibers tie it all together. So it's very complex. You also have the blood vessels coming in here. And many of you may have heard of these different zones called the red and the white zone. There's actually 3 zones. The white zone has fairly poor blood supply or vascularity. The red zone is over here and has a lot of vascularity. And then there's the red-white zone, which is a transition between the red zone and the white zone, and that's this middle third. And there can be different types of tears. A longitudinal tear is like a vertical type tear going through the entire meniscus. And it usually is a smaller section. A bigger longitudinal tear can create what's called a bucket handle tear, where that piece flips out of position. There's a radial type tear, which is a tear going directly across the meniscus like this. And if it has a vertical component, it can become an oblique or parrot beak type tear. And then there's a horizontal tear, which divides the meniscus into two pieces, called a horizontal cleavage tear. And there are also complex tears, which can be made up of any of these patterns. There's also a special type of tear called the meniscus root tear, and that's where it detaches off the tibia bone, most commonly in the posterior medial portion. And the consequence of these tears is significant. If you look at what the load and contact pressure or area, so the amount of pressure in a specific area on the tibial plateau or the top of the tibia bone, in a normal knee, when the meniscus is intact, we have this pressure here. However, when we tear the meniscus or we remove the meniscus, the pressure becomes statistically and clinically significantly higher. But if we repair or restore the structure of the meniscus, we can get back to that normal state. And this is on the medial and lateral side of the knee. And then when we look at the contact pressure and area, same type of pattern. And this is looking at the degree of the knee function. So in these deeper degrees of knee function, we see more stress and more pressure along that cartilage than in the normal state. There's another study looking at this, putting this contact sensor here and loading the knee joint in different settings of the tear or versus repair. With the higher in these partial meniscectomies, with these high pressures and these kind of what we call cooling maps here, you can see where blue is less pressure and dark red is more pressure. How is the meniscus injured? There's a few types. There's degenerative type, which is more wear and tear, in which the structure of the meniscus just becomes weaker. And through normal activity, like walking or kneeling or bending, the meniscus starts to tear and fall apart and become painful. So if you looked at a degenerative type, this would be a degenerative type tear, whereas this is what a normal meniscus would look like. And then there's the traumatic type, which comes from injury. And this can happen from a simple isolated meniscus injury, or it can happen in a bigger knee injury, like in the setting of an ACL tear or a ligament tear, in which case the femur and the tibia move back on each other and creates a meniscus tear. It's quite common to have meniscus tears when you have a ligament injury. Before early on, we thought it was probably about 18 to 20%, but a recent study out of our European colleagues show that in ACL tears, upwards of 60 to 65% of ACL tears have some form of meniscus injury. The symptoms of these tears create joint line pain. So right where the tibia and the femur come together, you'll see some pain in that area. You also may have some catching sensation, and that's more of the unstable type tears. You may have pain with kneeling. The knee may get stiff, particularly if there's a lot of swelling in the knee, or just in response to the pain or damage in the knee. And then, so let's say you have these symptoms and you come and see, myself and say, well, how do we figure out whether it's a meniscus tear or something else? And in this case, we use what you tell me, your history. We talk about the pain history. Was there an injury involved? And what symptoms you're feeling? I'll also take the opportunity to examine your knee, and particularly pain along the back of the knee is concerning for a meniscus injury. Pain with hyperflexion, because the meniscus is really going to get pushed back in the back of the knee when we hyperflex or hyperbend the knee. Joint line tenderness, as we described. There's a special test called the McMurray's test, in which we put pressure on the meniscus, and if we feel a pop or pain, that may be positive. And certainly in the acute setting, if there's a effusion or a lot of swelling in the knee, that would be concerning for a meniscus injury. We'll also use x-rays to help eliminate osteoarthritis, because one of the more common causes of these similar type symptoms would be knee osteoarthritis. And again, that's the setting in which the gliding cartilage, or the cartilage on the end of the bone, begins to wear away and degrade from wear and tear. And that's where we see these two bones coming together. This would be bone-on-bone arthritis or osteoarthritis, where you see bone spurs and the joint space is eliminated, whereas a normal knee will have some of this joint space represented by the cartilage and the meniscus. We may also get some alignment x-rays to see whether or not you're severely bow-legged or knock-kneed, because this can contribute to meniscus tears as well as arthritis. The MRI is very effective in helping to diagnose meniscus tears, as well as look at the quality of the cartilage underneath the knee. So we can look at quantity on the x-ray in terms of the gap, but the quality may be more important in terms of, is there a specific hole here in the cartilage? Is there degenerative changing all throughout the knee, as well as the response in the bone of these cystic changes? And then we can see whether the meniscus tear is there. So in this setting, we look at a finding called a ghost sign. This is specific to root tears, in which case this is the meniscus right here. The meniscus is circular shaped. So in this slice of the knee, we see a part of it in the front, part in the back. And as we go back, you can see the white represents fluid. And so that meniscus, which should be there, is missing because it's been extruded and pushed out because it's been torn off of the femur bone. And in this case, a more severe knee injury, you can see this lateral meniscus is flipped back up into this area and causing a lot of pain in this more traumatic knee injury. We can also diagnose these tears through what's called a diagnostic in-office arthroscopy. And this is a procedure I perform in my office. So it's under local anesthetic, put a small camera inside the knee, and we're able to see what's in the knee there. You can see, this is one of my patients here. We're using, oh, looks like, didn't like that. Hold on a second. But it's a procedure in which we can see inside the knee and be able to diagnose conditions. We're gonna have to restart this talk here. Stand by. I can try and see if we can make it bigger the next time I load it up. But this is a technique that allows us to look directly at the cartilage and directly at the meniscus and diagnose it, particularly in cases where people may have had prior surgery. It's very helpful. All right, let me share my screen again. Hopefully this is going to be bigger here. Move on to the next slide. So after we've diagnosed the meniscus tear, our next discussion is what options do we have to help move forward and fix this problem? So, first off, anytime we want to consider non-operative treatment, it has the least amount of risk. And in cases where we have a stable or small meniscus tear, this is our go-to to try and manage this. So we often use physical therapy to address knee motion and strength and balance. Most importantly, to allow us to continue to be mobile and active while not putting excessive force on the meniscus to give it its best chance to heal, particularly if it's in the red-white zone. We'll do some activity modification to avoid impact and twisting activities, again, to maintain the stability of the meniscus tear and give it its best chance to heal. Sometimes, if there's a lot of inflammation in the knee joint, we may consider a cortisone injection just to decrease the associated inflammation with the tear. And platelet-rich plasma has been tried numerous times. This is an investigational treatment. It's been studied very well in knee osteoarthritis, but not in isolated meniscus tears. We've had some potential healing for stable meniscus tears for patients who are not a candidate for surgical treatment. But again, this is investigational, and unfortunately at this time is not covered by insurance. A surgical option called meniscectomy is an arthroscopic or minimally invasive procedure to remove the torn portion. And so in this case, the torn portion is trimmed back in the knee. And so in this case, you can see this tear type, this area of meniscus was not able to be healed very well. So we use tools to go back and trim back this area of damaged meniscus that's flipping and catching in the way and causing pain and physical discomfort to our patients. But the most important concern, the thing that you should take out of this, is that this can initiate onset of knee osteoarthritis. So we need to be very careful in our use of meniscectomy, making sure we don't resect a lot amount, and particularly when we have the opportunity to repair, we take that opportunity to repair. So in this case, we can see the meniscus here had a root tear. We've sewn that back. We can see back here there are some stitches. So my preference is to try and repair these meniscus tears versus resecting them. And then lastly, we can try the opportunity in some cases when the meniscus has been resected and there's still pain, we can use meniscus transplant. And in this case, this is what's called a collagen meniscus implant, or CMI, which is used as a synthetic meniscus transplant, which gets sewn into the meniscus and then allows this to be populated with patients' mesenchymal cells that will come from the red zone and fill this area, and it will become part of the meniscus. The more classic treatment is with a meniscus transplant, and that's where we take donated tissue, allograft tissue from someone who's passed away, cadaver tissue, and we replace that into the knee joint right here by securing it down through these tibial tunnel bone holes and stitches, and we sew that meniscus in place. But the most important thing is to try and save the meniscus. I showed you some other studies looking at contact stress in the knee. Here's another one just looking at contact pressures when we even have a relatively stable tear, like a horizontal cleavage tear. Those two tears where the two flaps are tied on top of each other. And even in this setting, you know, the repair is showing clinically significant pressure in the knee joint. And by taking that out, we don't improve that contact stress. Only when we repair it are we able to restore it back to its normal state. And this is what I was talking about earlier. There's a 70% increase in knee osteoarthritis in 10 years once we do this. So even though you may have initially a good result after having your meniscectomy, it increases over 10 years and could develop into osteoarthritis and damaged cartilage, which cannot be restored with an arthroscopic procedure. And you're looking more at like either chronic knee pain or knee replacement surgery. So some of the knee repair techniques, we have lots of different arthroscopic techniques, whether we're using sutures to sew all inside the knee joint, or sending sutures from the inside to outside the knee joint, or using tools to put sutures in the meniscus, secure that back down to the tibia bone. So this is an outside in repair in which we are placing the camera in there, and we have these tools, these needle tools, and we're able to pass stitches down the meniscus, down through the meniscus, and sew that meniscus back to the knee capsule where it belongs. So we can sew that back to each other. And this is what's called an outside in, because we're passing the suture from outside to in. Other techniques are the all inside technique. And this is a technique where we are going to sew the tear back. So we're going to use this rasp to help repair these areas. And we're going to use a tool that's going to pass suture around the tear and tie it back. This is what's called a circumferential repair. And so in this tool, it's going to pass the suture around the meniscus and tear, and then we're going to tie a knot around that stitch and sew it back to where it needs to be. And with adequate time of healing, typically around 5 to 6 months, patients are able to get back to a very athletic lifestyle and return to sports. So that's kind of the all inside technique. And then the inside out technique is where we pass needles from inside the knee joint to outside the knee joint. In this case, we need to make a small incision in the back of the knee to catch these needles, and we'll sew this meniscus back like that. And we have to put sutures on this side and this side to help restore the meniscus. And then the root repair, when we're drilling tunnels in the knee. So here you can see this is the meniscus where it needed to be attached. That's its attachment has been chronically torn. And we use a tool to help prepare a bony bed for this meniscus to heal back into, making sure the meniscus can go to that point. We'll actually release some of that tissue to help make sure the meniscus is mobile. And then we'll drill some small holes from the outside of the bone to the inside of the knee joint that we're able to pass sutures up to. There's that drill hole that we're drilling. And we'll pass some stitches in the meniscus that will allow us to then bring this tissue down, bring these sutures down these tunnels and help reduce that meniscus back to the tibia bone and heal it, allow it to heal. So here we are passing these stitches down the two tunnels. Requires some steady hands to be able to grab all these sutures. And then once those stitches are down inside the bone, we're going to tie those down over the bone using a special implant that will secure them in place. But you can see that's going to restore the meniscus back to its attachment to the tibia and then restore the function of the meniscus. So a lot of people say, well, do these work, right? And some people say, oh, a doctor told me that I'm over 40, so it's not going to heal. And this has been studied in multiple studies and then put all together in what's called a systematic review or a meta-analysis, looking at all the studies put together. And multiple studies looking at midterm, short-term, and long-term data show that meniscus repair has much more clinical benefit over meniscectomy. There's a higher likelihood of healing when there's an ACL reconstruction. And this is why we use some tools to help augment the healing during the surgery so we can get the same rates of healing as we do with ACL. And then, but the most important thing is osteoarthritis is the largest factor to determine failure rather than age. So if you already have arthritis in the knee joint, having an arthroscopic meniscus surgery is not going to be helpful for you because it's just going to increase the pressure on this already damaged knee, and it's going to cause pain and your risks of blood clots and anesthetic risks as well as infection for not a lot of improvement. And at 12 weeks, we can already see the meniscus starting to heal. Rehabilitation is significant. So some of you may have had friends or yourselves have had meniscus surgery in which you had the meniscectomy and you're off your crutches quickly. When you do a repair, it's a much slower recovery because we need to get that tissue to heal. So you need to be prepared to be using crutches for about 6 weeks. We're going to use a brace called a knee immobilizer that will help stabilize that knee so we don't put a lot of pressure across the repair. We start getting range of motion back in the knee, and you can return to full activity at 5 to 6 months after surgery. There's already been a question here in our Q&A. We're going to address that right now. What if you have underlying osteoarthritis? And that's probably the most important thing to pick up from this talk, is that while you may have a meniscus tear with arthritis, treating the meniscus tear alone is not going to solve your knee problem, your knee pain. And so if we use our tools of diagnosis of x-rays and MRI and in-office arthroscopy to help determine whether or not we're seeing these osteoarthritic changes, whether they're in the middle stages or severe stages, we need to use other tools in our toolbox like anti-inflammatories, Tylenol, platelet-rich plasma injections, or other types of injections like cortisone or hyaluronic acid, bracing to help unload areas of the knee, physical therapy to help improve the function of our knee, and in some cases, when all of these tools are no longer helpful, using total knee replacement to resurface the knee and allow you to get back to an active lifestyle. So in summary, meniscus tears are common. They can occur with an injury or on their own in a degenerative setting. The treatment should include non-operative treatment, and in some cases, surgical repair. And which one we choose is dependent on the severity of pain and disability, whether or not there's underlying arthritis in the knee joint, as well as the tear type of the meniscus and how severe it may be. And meniscus repair has an excellent outcome and can slow the progression of future knee osteoarthritis. We are also currently recruiting patients to a clinical trial. It's a multi-center trial all over the United States, in which we're looking at outcomes after horizontal and complex meniscus tears. We've already shown excellent outcomes clinically with meniscus repairs, but now we want to show the radiographic and clinical outcomes in a 2-year study in which we're enrolling 90 patients. We're actually even going to go back and do MRIs after the surgery, as well as that diagnostic arthroscopy to kind of document the healing. So if you're interested in participating, please feel free to go to clinicaltrials.gov. You can contact my office for further information. So we started this talk with a slide about a lot in the news regarding meniscus tears, talking about how it may not be helpful and you should be weary. Well, I'll posit to you that, in the right hands with the right type of tear, we can fix people's knee pain with the appropriate surgery to restore and preserve patients' knee. And this is an article about one of my patients in the Washington Post who had a knee injury, kind of meniscus root tear. She was actually able to get back to running after we were able to restore her knee function with a meniscus repair. And we've even had some studies looking at, we even had a news piece done on Channel 4 looking at how we restore patients' knee function and using repair versus performing a meniscectomy. And so this is just another video of that device, in which case we can actually sew the meniscus back to itself rather than trying to just reapproximate it. So I want to thank you all again. I want to thank the Gildenhorn Institute for the opportunity and the support to put on these meetings. And I also will go back now for the Q&A section. If any of you would like to schedule an appointment with me, please feel free to email us at appointments@scottfawcettmd.com, or you can call this number right here. But now we'll move on to the question and answer session. So the first question that we had here is perhaps related to the implications of osteoarthritis. How does age affect prospects for beneficial surgery to correct a meniscus tear? So there's two questions in that setting. And the first is age. So I've repaired meniscus tears in a 77-year-old woman who is very active, had no cartilage injuries in her knee, no signs of osteoarthritis, but sustained a meniscus root tear. She went from being able to walk 2 miles every day to not being able to walk at all and being in a wheelchair. We repaired her meniscus, and within 3 months, she was able to actually be able to get back out and walk for a mile. And in 6 months, she was back to walking her 2 miles. So age is not a factor. It's the role of arthritis in the knee joint. And arthritis is kind of like a train headed on the tracks in one direction. We can slow it up, and it can be sped up and it can be slowed down. And what we want to do is try and manage that as best we can, but we can't reverse it. We haven't had any tools yet to reverse osteoarthritis in a systematic fashion. And so when we have arthritis, we don't want to be doing interval surgery just to fix something we may see on an MRI. We really want to show improvement in our patients. So if you have arthritis, I would recommend using the non-operative tools to manage that. And if we don't have arthritis, we can consider more treatment for the meniscus tear. So thank you for that question. The next question here says, good evening. Tore both of my menisci on September 28, 2014 in a horrific motorcycle accident. I'm so sorry to hear that. One said that I opted surgery, he would slice off the torn loose tissue, and based on the side tear, I have oblique tears. Been treated with anti-inflammatories for years. In April 2020, twisted the knee and now have pain again. Yet a cortisone injection resolved the pain. However, the pain keeps coming back. So in terms of your case, I can't specifically address any comments about your case, but I would encourage you to consider seeking treatment and consideration of, potentially repairing this. Questions of having tears on both knees, it's hard to recover from those. We typically don't operate on both knees at the same time, just because of the weight-bearing implications. But I'd be happy to help you in an office visit if you'd like to consider that. But I can't specifically comment on any of your specific treatment, but those oblique tears can be successfully repaired. The bigger concern is whether or not there's osteoarthritis. So this is a great question here. What causes post-arthroscopic osteonecrosis, and what can be done about it? So the number one factor for post-knee arthroscopy osteonecrosis is actually from excessive force on the knee because the meniscus has been removed. And this is most commonly seen in those root tears, where they have the biggest clinically and statistically significant change in the contact forces. So if you go and have arthroscopic resection, in this case of a root tear, this can be rapidly progressively developing osteonecrosis and our osteoarthritis. We actually published a study looking at the outcomes after comparing non-operative treatment, meniscectomy treatment and meniscus root repair, and the role of developing osteoarthritis and needing knee replacement surgery. And it showed that meniscus root repair was both clinically significant and superior to meniscectomy versus non-operative repair, as well as saving money in the health system over a long period of time and avoiding having to do knee replacement. In these cases, over 50% of people needed had knee osteoarthritis within 5 years, and 35% of patients who had meniscectomy needed total knee replacement in 5 years, versus no one in the meniscus root repair. So that's probably where it came from, and that's where we see it often. Unloading brace can help, as well as in appropriate cases, meniscus transplant if there's no tissue to restore back in that setting. The next question is, if one has already had a partial meniscectomy, is repair even an option? So another great question. So if the tear has already been removed, no, we can't go back and repair the tissue that's been removed. We can, in some cases, it may be indicated to do what's called a meniscus transplant, where we take either synthetic meniscus tissue or donated cadaveric meniscus tissue and replace it into the knee joint. And that would if you're having clinical symptoms without any signs of osteoarthritis. If there's a new tear after you've already had a meniscectomy, then that tissue can potentially be repaired in an attempt to restore more tissue, but we can't put in new tissue. Next question here. My doctor said that I have a worn out meniscus plus some arthritis. He said that I was not a candidate for surgery. I'm concerned about the injections of cortisone suggestions. Thank you for that question. There has been a lot of news regarding that cortisone can cause arthritis. And there are some flaws in that study. Certainly, cortisone can reduce the pain that you feel in the knee and decrease inflammation. However, often with cortisone injection, we also may inject an anesthetic. And that anesthetic has also been shown to cause cartilage damage in the knee. So we don't really know whether it's the cartilage or the anesthetic, but also more importantly, we don't know whether this is just the train of osteoarthritis progressing in one direction. And so obviously people who are in more pain, who have knee osteoarthritis, are going to be willing to do something more invasive like a cortisone injection, whereas people who have less pain or minimal pain may not be needing to do these cortisone injections. And if your cortisone injection makes your knee feel better, then you're more likely to go back and get a new one so you can maintain that activity. Meanwhile, knee is becoming more and more degenerative. Whereas if you're avoiding the cortisone injections, you're going to have more knee pain and you're going to be decreasing your activity, lowering your activity level. And so the knee pain may not proceed as fast. So there's a lot of factors that go into this, but we have not seen any studies that show that actual cortisone medication itself causes deleterious effects on the cartilage cells. So certainly don't want to inject cortisone in your knee if it's not hurting, but if you are limited in your activity and you can't walk or move, cortisone may be a reasonable thing. Recently, multiple studies have come out looking at platelet-rich plasma injection combined with hyaluronic acid combined together, and those have shown superior outcomes with more longevity than cortisone injection. So that might be another thing you might want to consider if you have arthritis. Another question here. Based on your talk, if you already have knee arthritis and a meniscus tear would not be beneficial, knee replacement is the only option. So I would say I would be very cautious with proceeding with arthroscopic surgery because the interval change is probably not going to be helpful, and that you're better off treating this with physical therapy and anti-inflammatories. That's what some of those earlier studies talked about when you compare patients who had, had pain in their knee and they were presented to enroll in the study, in which case they could opt for arthroscopic surgery or have no surgery. And they flipped a coin and assigned them. And then they followed them. And for those patients, they showed no clinical difference at 1 and 2 years after they had the surgery in terms of their pain or knee function. So in that case, I wouldn't recommend taking on the risks of anesthesia, surgery. These are relatively low risk, but they're greater than zero. And if you end up the same as you were before, probably no benefit. So it's important to notice in those studies, meniscus repair was not an option, and these patients were showing signs of moderate grade osteoarthritis, so degenerative type knee conditions. So that's not the case in this case where we have good cartilage with a meniscus tear. Next question, is meniscus repair done arthroscopically? For the most part, yes. It's done through two small incisions to allow the camera to go in and see inside the knee joint and access some of the more tight areas that we can't normally see in open surgery. In those rare cases, in which case we need to do an inside out, where we make a small incision in the back to catch the needles safely at the back of the knee, or in the cases where we have to do a root attachment where we sew it down on the bone, there may be a smaller incision to be able to access those areas. But in general, it's all done through minimally invasive type techniques or arthroscopy. All right. The next question is 67-year-old, walked 4 to 5 miles, 3 to 4 times a week, had a knee MRI and told there's a tear in the meniscus along with some arthritis. There is knee cartilage, but told by an orthopedic surgeon to do nothing for the time being, continue to remain active and take Tylenol as needed. Occasionally take meloxicam for inflammation, and now you walk 2 days on and 1 day off. Recently refused cortisone injection because no severe pain. Again, it's hard for me to comment exactly on your question, but certainly if you're not having significant symptoms and you're able to achieve your mobility, your desired mobility, certainly activity modification, physical therapy, and occasional anti-inflammatories may be the best option for you in this setting. So it's just kind of dependent on the role of arthritis. And you start seeing cartilage thinning, I definitely recommend caution with arthroscopic surgery, as it's not going to be able to restore the knee cartilage back to the knee where it needs to be. All right, we have one more question here. Let's see. I have a question here. Had an arthroscopic repair 8 weeks ago. Healed beautifully with physical therapy, but still have much pain at night, even with painkillers. I'm sorry, I can't comment on your case. I definitely would recommend following up with your orthopedic surgeon to better understand. But even at 2 months, it's still fairly early to kind of assess your outcome. Another question here, can you re-explain the parameters used to determine when to trim the meniscus and the recovery time? So, for meniscectomy, and in my practice, is really only for tears that are not repairable. So if I go in there into the knee joint and I see that the tissue is just shredded, right? So I'll go back to this picture here. You see tissue like this, where there's just, pieces of meniscus tissue everywhere, and there's no real planes in which we can sew things back. This is very difficult to sew back, but sometimes this pain, but the cartilage itself looks pretty normal here. And so we're not in an arthritic session. And so in these cases, trimming out the meniscus will help prevent like a knee catching or progression of the tear. And that's where we just kind of smooth and trim this out. But in cases in which we have good planes and good tissue, sewing that back is going to provide the best option to preserve that knee. Recovery time after meniscus repair is longer than meniscectomy. And so that is in case where we need to keep your leg locked out for 6 weeks. You'll be using crutches for 6 weeks, and then take another week or two to wean off of the crutches so you can walk normally. And then, looking at the recovery time, getting back to sporting activity at around 5 to 6 months. We have one last comment here. It says, I had a loose meniscus flap removed in May of 2019. Since then, I dropped 20 pounds and bike a lot and no longer have any knee issues. Well, I'm very glad that helped you. That's great news. Sometimes just getting out that loose flap is all people need. But in my practice, we try and restore the function of the knee to kind of get it back to normal and get those pressures back. It looks like you've helped your knee quite a bit by losing weight and doing a low impact activity like biking. So that certainly can help preserve your knee longer in that setting. All right. I don't have any more question and answers. I don't have any more comments in the chat section. So I think, Kathy, at this point, we will adjourn.
Sounds good.
Thank you all again for coming and joining me this evening. And I hope you all learned a lot. And if you have any further questions, you can always just email me at, let's get here. You can email me at appointments or just Dr. Faucett at scottfawcettmd.com. That goes directly to my email account. You can learn more about meniscus tears on my website. And if you want to make an appointment, 202-912-8480. And I look forward to seeing you all if you need my help. Otherwise, have a great evening and all the best to you.